Good afternoon, everyone, and thank you for joining today's webinar. My name is Kimberly Galbraith, and I'm PPMD's COO. Today we are excited to dive deeper into the topic of genetic testing, test interpretation, and why understanding this information is really critical for every family facing the diagnosis of Duchenne and Becker muscular dystrophy. PPMD and Sarepta Therapeutics joined forces on a genetic testing program for patients with Duchenne muscular dystrophy in 2013. And through the genetic testing program called Decode Duchenne, PPMD provided testing at no cost to eligible patients who are unable to access testing due to barriers such as lack of or insufficient insurance coverage. The Decode Duchenne program has been invaluable for the individuals with Duchenne and their providers. Numerous families have reported that they are extremely grateful for this service, as their loved one would not have been able to have genetic testing otherwise. In addition, providers have been very appreciative of the Decode Duchenne program since they can offer genetic testing to all of their Duchenne patients regardless of the financial situation. This program has also impacted relatives of Duchenne patients because once the mutation has been identified in the affected individual, then at-risk female relatives can have carrier testing performed. Based on the belief that all patients with Duchenne should have the opportunity to receive genetic testing in order to understand their genetic mutation, have confidence in their diagnosis, and learn about opportunities to participate in clinical trials, this program addresses barriers to genetic testing in Duchenne that have long frustrated healthcare providers, patients, and their families. This year, and actually just early last month, PPMD was thrilled to announce the continuation and the expansion of Decode Duchenne program. We are especially excited and extremely grateful that the Decode Duchenne program is now being supported in collaboration by 3 companies: Sarepta Therapeutics, PTC Therapeutics, and BioMarin Pharmaceuticals. This collaboration is the first of its kind in the Duchenne space, and we are very grateful to these companies. The newly expanded Decode Duchenne program will continue to provide free genetic testing, interpretation, and most importantly, supportive counseling for people with Duchenne or Becker muscular dystrophy. This expanded capacity also ensures that both families and care providers are educated around participation in clinical research and mutation-specific therapies. I would like to now introduce Ann Martin, who is one of PPMD's genetic counselors and a Duchenne Connect registry manager. Again, thank you very much to Sarepta Therapeutics, PTC Therapeutics, and BioMarin Pharmaceuticals for your support of this program. Ann?
Great. Thank you, Kim. So my name is Ann Martin. I am one of the genetic counselors at PPMD and one of the Duchenne Connect coordinators. And today I wanted to talk about kind of the logistics of how the program works. And basically we did set the program up to be as simple as possible. So hopefully those of you who have participated in the past would agree. To get started, who is eligible? So to participate in Decode Duchenne, of course, the patient either has to have a confirmed diagnosis of Duchenne or Becker or a suspected diagnosis, and that would be based on the assessment of the doctor based on the patient's physical features as well as an elevated CK level. A lot of the patients coming into the program have not had previous genetic testing, but we do accept a lot of patients who have had previous genetic testing that was inconclusive. So if you had previous testing and the mutation was never found, or if your testing was done a long time ago using a technique that is no longer considered an acceptable technique. So you can certainly participate in this program if you're in that situation. So the program was designed for families with financial hardship, but we have a pretty broad definition of financial hardship. So, of course, it's families who don't have insurance or families maybe who have Medicaid and Medicaid won't cover genetic testing. But we also have a lot of people coming into the program from private insurance where their insurance will not cover testing or will only partially cover testing. And even for families where just the copay or the deductible would prohibit them from being able to get testing, we will accept them into the program as well. So we're really trying to include as many people as we can into this program. The program is set up for citizens or legal residents of the United States or Canada, and the last requirement is that all of the patients or families register on Duchenne Connect. And that's because we will upload the genetic test report into the patient's account, but also, so for the families, all of you can benefit from being a member of the Duchenne Connect registry. Okay, so in order to actually apply for the program, and this sometimes comes directly from parents, but often it's coming from your healthcare provider, your doctor or nurse or genetic counselor. One of you just needs to go to DuchenneConnect.org and print out an application form. If you'd rather call us or email us, you can do that too, and we can either email you back the application form or fax it to you, whichever is easier. If you do go to our website, so this is the home page for the Duchenne Connect registry, and you'll see right there on the home page that the Decode Duchenne program is highlighted. So all you need to do is click on the Decode Duchenne program, and you'll be taken to the landing page, which has more details about the program, such as who can participate, which is what we just reviewed. But you'll see down towards the bottom where the arrow is, where you can download and print the application form. And this is a copy of the application form. It's just one page, so it's really simple to complete. We just ask, of course, for the patient's name and date of birth, and then you have to select, what difficulties they are having in terms of insurance coverage, or if they don't have insurance or whatnot. And then the physician or nurse or genetic counselor will need to mark what level of testing has been done in the past, so we're aware of that. And then we just need the healthcare provider's information, their contact information. So that's it. Pretty simple. That form is then emailed or faxed back to us, and then we will notify you within 1 to 2 business days of acceptance into the program. And generally, we're dealing directly with the healthcare providers, but we can also deal directly, with patients as well. So once we get that application and you've been accepted into the program, then we will send you the forms that are needed for testing. And we do have a contract with Emory Genetics Laboratory for all of the testing that's done through Decode Duchenne. So we will send you a specific requisition form just for the Decode Duchenne program. And that's important because that means the bill comes to us and not you. We'll also send you information about the specimen requirements and shipping and handling instructions. And if a lab kit is needed, we can get that for you as well. Some hospitals and clinics are fine without an actual kit, but if your doctor's office would like a kit, just let us know and we can order those from Emory and have them sent to you. Okay, so once you have all of the Emory information in hand, then it's just a matter of getting the blood draw scheduled. And if the forms did go directly to you as a patient or family, just make sure you bring those Emory forms with you to your blood draw appointment. And we do want to point out that the actual blood draw, the phlebotomy charge, is not covered by our program, but we do cover the entire cost of the genetic testing through Emory. Okay, so in terms of the reporting, the results usually do take about 3 to 4 weeks for the first level of testing. And then if an additional level of testing is needed to find the mutation, then that could be another 3 to 4 weeks. But all reports will be sent directly to the ordering physician on that requisition form. So make sure that information is completed on the requisition form. We do get a copy here at the registry at Duchenne Connect, and we will upload that into the registry account. But you will be hearing from your doctor, so your local doctor's office will be contacting you with your results, and we do that just so you can keep that relationship with your local office. But, of course, we are available here at Duchenne Connect with myself and my colleague, Ann Lucas, who will be speaking in a moment. We're both certified genetic counselors, and we have many years of experience working in a neuromuscular clinic and working with Duchenne families. So we're here to help in any way we can. So please email or call us. And even if you haven't had your testing done through the Decode Duchenne program, but you have questions, please call or email us, because that's what we're here for. We can provide result interpretation and genetic counseling and talk about the impact for you and the rest of your family. And one other thing I wanted to note was carrier testing. I know that's often a question that we get, is whether carrier testing can be done as part of the Decode Duchenne program. And it is not part of the program at this time, but we have just recently negotiated a reduced PPMD rate through Emory Genetics Laboratory. So if you yourself, listening today, if you need carrier testing but haven't been able to get it done, or if you're a provider and you have a lot of women who would like to get carrier testing, please contact us, because we have a requisition form that you can use so that you can get the reduced PPMD rate for the carrier testing. And this is for testing when the mutation has already been found in the family. And it is self-pay, so when the sample's sent in, it would have to be accompanied by check or credit card. So contact us if you'd like more information about that program. So we are excited to at least be able to offer carrier testing at a reduced rate now. Okay, so right now I'm going to turn it over to Dr. Stan Nelson. He is a professor of human genetics at the David Geffen School of Medicine at UCLA. He's been an advisor with Duchenne Connect for many years and has been involved with us in our PCORNet project and has really been active with PPMD for many years. So I'm going to turn it over to Dr. Nelson. He's going to talk more about what genetic testing is and some of the methods involved, and more importantly, why genetic testing is so important for you and your family. Great.
Thank you, Ann. Hopefully I'm audible by everybody. Good morning or good afternoon. So as Ann said, I'm a professor of human genetics, and there's one of my roles in our own clinic is describing genetics to individuals with Duchenne and Becker muscular dystrophy. One of the things that is been substantially altered in the diagnostic process occurred when the dystrophin gene, DMD, was cloned now over 25 years ago, allowing specific molecular diagnostics. Right now, there are many different clinical trials coming forward which are going to mandate knowing the exact mutation, but also often just simply knowing the exact diagnosis because of genetics is going to be a required entry to some of the clinical trials as we head forward. And so this is actually quite relevant to all of us in terms of how we move forward and get people easily into clinical trials. This is a fantastic program. Very happy that PPMD and Duchenne Connect have stepped up to be able to do this with the companies. So the DMD gene is on the X chromosome. It's an X-linked recessive disorder, which means that males in the lower right-hand corner are XY and females are XX. And because the mutation is on the X chromosome and males only have one X chromosome, the disease manifests in boys. So X-linked recessive inheritance, in this example, blue is a normal gene and white is an abnormal gene. And an affected son is indicated in white below. And this means that the mother will always contribute an X chromosome. In this instance, the mother is a carrier. So one X chromosome has the blue non-mutated DMD gene. The other X chromosome has the white mutated gene. And when it's transmitted from mother to boy, the boy has a 50-50 chance of getting the mutated chromosome, which is on the far right, or the non-mutated chromosome, which is on the far left. So 50-50 chance of having an unaffected son or an affected son. And again, similarly, daughters have a 50-50 chance of being a carrier or having neither chromosome affected, which is an unaffected daughter in this example. As many people on the phone probably know, even with Duchenne, since the DMD gene is one of the most commonly mutated genes generation to generation, oftentimes we see a scenario where the mother is not a carrier, but the son is affected, and that's due to de novo mutations, often germline mosaicism in the mother. The basics of chromosomes and genes. So on a single chromosome, so out of the 23 pairs of chromosomes, one pair of chromosomes is either XX in a female or XY in a male. And on that one X chromosome, which is over 200 million letters of the genome long, there will be a couple thousand different genes encoded on the X chromosome. In total, we have about 24,000 individual protein-coding genes in all of the chromosomes, making us us. And one gene, so we define a gene unit as the beginning of where the transcriptional machinery starts to where the transcriptional machinery, where an RNA is made, ends. So that's quite large. So for the DMD gene, it's over 2 million bases or letter codes of G, A, T, or C to encode the entire gene. But that's broken up into individual exons. So a very important component of what we understand about all genes is exons are the protein coding part of the gene, and introns are the part of the gene that's in between each exon. So the machinery of the cell knows how to splice and put together and take a gene, which is the DNA, make an RNA, which is copying that gene completely, but converting the RNA into an mRNA, which actually makes the protein. So exon 1 gets joined very precisely to exon 2. Exon 2 gets very precisely joined to exon 3. And most of the gene is actually all of these intronic bits, which get completely removed when we go about making the full-length mRNA to make the protein. So, but there can sometimes be important mutations within the introns that affect the protein coding sequence and that disrupt the gene. So we have to be aware of the introns. But for the most part, most people will have mutations that are large deletions or duplications or point mutations either in exons or immediately flanking exons are the vast majority of the solutions that are found in individuals. Dystrophin is a huge gene, and it's encoded by 79 of the individual exons. And so this is a reading frame map, which many people in the field now look at rather regularly. It's a very important part of how we understand the gene and how we understand how we might be doing various repair strategies like, for instance, exon skipping. So this reading frame map is converting the three-letter DNA to RNA code into one letter of amino acid. So 3 letters of DNA are 3 letters of RNA, but every 3 letters of RNA becomes 1 amino acid residue. So any of the mutations, and most of the mutations in Duchenne, cause a frame shift. They're large deletions, and those large deletions result in a protein coding frame shift change that results in no functional protein being made. There's other mechanisms to also make no functional protein being made. So in this table of types of DMD mutations, deletions account for the vast majority. So most people will have deletions where there was a breakpoint in one intron and then another breakpoint in another intron some distance away, and all of the DNA that's between those 2 introns is missing, including many different bases of the exons. So oftentimes people will talk about having an exon 45 deletion or an exon 45 to 50 deletion. Those would be 2 reasonably common types of mutations. And what that means is that there's that whole piece of genomic DNA is missing from the X chromosome and does not result in the ability to make a functional protein. So deletions account for the majority of mutations, and when we say deletions in DMD, we mean large tens to hundreds of KB deletions, and sometimes millions of bases are deleted from the genome. Duplications are a relatively similar mechanism, but instead of a bit of genomic DNA being missing, a part of the genomic DNA is duplicated or repeated. Usually it's the sequence is repeated and it's in tandem, but we don't necessarily always know that from the genetic testing. But what one can infer from duplications is presuming that they're tandem and presuming that they're in frame. So if you had an exon 2 duplication instead of exon 1, 2, 3, 4, it'd be exon 1, 2, 2, 3, 4. And that would result in an out-of-frame mutation, for instance. But even if it were in a different orientation, it would also disrupt the protein production completely. Small point mutations, the bottom category, account for a smaller fraction, and they include very small insertions of even just a single base can disrupt the protein coding sequence and would be frame shifting. 2 bases would be frame shifting. 4 bases would be frame shifting. Pretty much anything that's not an even multiple of 3, that's a small insertion or deletion of just a few letters of DNA code. There's also an important category which are nonsense mutations, which means that the base change from encoding an amino acid to encoding an early stop signal in the RNA so that the protein translation stops very early. And that results in Duchenne muscular dystrophy and no functional dystrophin protein being made. And then the other important category, which is sometimes not entirely clear what it does to the protein coding sequence unless we've observed it before in other boys or we have a muscle biopsy, are splice site mutations where the splice sites are actually in the intron sequence. So they're not going to be part of the mature mRNA. They're not going to be part of what encodes the protein coding sequence. But if we mutate, for instance, the 2 bases immediately before any exon or the 2 bases immediately after any exon, they always disrupt splicing, and other bases around the exons can also disrupt splicing. And those can sometimes lead to exclusion of the exon or using an alternate place to start within the exon. So those become a little bit more of a mystery. We don't necessarily know for sure what their function is at the RNA and protein levels simply by them being splice sites. But for the most part, they lead to frame shifts, and no functional dystrophin is the typical answer for those types of mutations. The spectrum is a bit different in Becker muscular dystrophy, which tend to be in-frame mutations, resulting in some functional dystrophin protein expression. So the way DNA testing works is because we know we're looking for large deletions or large duplications, there's a relatively inexpensive, straightforward, very accurate test which we developed many years ago, which is called multiplex ligation-dependent PCR amplification, or array CGA. Both are very accurate methods that can very reliably observe the types of mutations that occur in about 3/4 of all Duchenne patients. And so this is the first step of testing, and when a blood sample is sent off, genomic DNA is made, and that is sent off for testing of this type. So the 2 different assays that are commonly used, the first is multiplex ligation-dependent probe amplification, and this is just a slightly fancy way to do PCR, and what one is doing is taking all 79 exons and amplifying each one in an affected boy. And if genomic DNA is missing, there's nothing for the probes to bind to. There's no product. And so when one makes a ladder, which is indicated down below in this fragment analysis, either 1 exon might be missing or multiple exons that are typically in succession. So if exon 45 is missing, you'd want to know, is 44 missing as well? Is 46 missing as well? 46 is missing, is 47, et cetera, to know how big the deletion is and to know what the boundaries of that deletion are. And that is all done simultaneously currently in most of the labs to find what are the boundaries of the mutation, to say what are the exons that are deleted. Similarly, one can actually quantify the amount of PCR product. So a duplication would look like twice as much PCR product as you expected. And again, you see multiple different adjacent exons having more signal than you'd have expected. And it's quite a reliable technique for those deletions and duplications. This is the large deletions and duplications. An alternate method is called array CGH, or comparative genomic hybridization, and this is performed in a number of different ways. But essentially what's happening is a patient's DNA, so the affected boy, is identified in the green tube here, and his genomic DNA is purified, labeled in this instance with a green fluorescent probe, and compared to a controlled genomic DNA of a boy who does not have a deletion in the X chromosome. And those two genomic DNAs are mixed together and hybridized or bound very specifically to an array of oligonucleotides or short DNA sequences that are going to bind. And again, if there's no binding, one will infer that there's a deletion. If there's more binding and there's a higher signal, one would infer that there's a duplication. And this testing is highly accurate. There's multiple different probes that are being used to record every single exon. So this actually becomes quite a nice technique and gives quite accurate information for deletions and duplications. This can be done, of course, throughout the genome. For Duchenne, what we care about particularly is the 2.5 million bases where the DMD gene is encoded. If those are both negative, which occurs in about 25% of the testing, you would typically either have done MLPA or it would have been array CGH, and those are reporting these big deletions and duplications that most people have. So for the most part, that testing finds the mutation and one's done doing genetic testing, and that allows you to have a reagent to know what the mutation is in the boy to perform first-degree female carrier testing or test other suspected affected boys in the family, and would let you know exactly how to go about doing that testing. The second step of testing, if the first is negative, if it doesn't reveal any mutation, is to sequence the DMD gene. And that entails, that's actually more work and is a more difficult test, but it's, again, completely reliable, completely standard, done in multiple different laboratories. And this entails using PCR primers to amplify each individual exon. So all 79 exons are amplified, and one uses a technique developed by Fred Sanger many years ago to do capillary electrophoresis and creating a ladder of DNA sequences to very accurately and very reliably observe a mutation on the X chromosome. Since boys only have one X chromosome, you're only observing the chromosome that came from mom, so the sequencing ends up being very clean, tidy, and straightforward. Again, if a point mutation is identified, often it'll be a nonsense mutation. Sometimes it could be a small deletion causing a frame shift. Sometimes it can be in the sequences immediately flanking the exons and cause a frame-shifting splice site mutation, and all of those are detected by this type of sequencing method, which is what are used currently in laboratories. Testing methods may shift over time, and indeed at Emory offers, through their excellent clinical genetic services, they offer a neuromuscular gene panel. So that would be, there are diseases that present much like Duchenne muscular dystrophy, and yet the individuals never have a DMD mutation because they have a mutation in an alternate gene that affects another limb-girdle muscular dystrophy that's much more rare, typically autosomal recessive in one of the other 22 pairs of chromosomes. And those can be reliably detected by a panel. At UCLA, an alternate way that we go about solving some of the cases is through whole exome sequencing, where we sequence every single gene in the human body and search for, again, alternate explanations other than the DMD gene. We do have some instances where our whole exome sequencing has found a mutation in the DMD gene that was missed for technical reasons, and these sorts of things happen in laboratory testing. We also have instances where whole genome sequencing, where we resequence all 3 billion letters of the human genome, has identified some cryptic mutations deep inside introns, inversions, chromosomal translocations that are balanced and not causing any other problem other than breaking the DMD gene. So there are always a few percent of patients with mysterious mutations that cannot be solved by the current clinical testing. And some of these new methods will ultimately be able to get at those. So genetic testing is essential and is really a core part of what we do in clinic. It's essential that all of you push for it. It would certainly a shame and shameful that some insurance carriers aren't covering it well, or some of our state-funded programs are not. This program is intended to fill that gap, of course. What it does is it allows you to have great confidence in the specificity of the diagnosis, that Duchenne muscular dystrophy is always due to mutations that lead to a lack of dystrophin because of mutations in the dystrophin gene. And we should be able to find those in almost every single patient. So it allows you to have great clarity of the diagnosis, and there's no questions about it. It's important, particularly for family planning discussions, getting appropriate genetic counseling in terms of, is it a de novo mutation? Is it inherited from mother? Who else is affected in the family? Or is it risk of transmittance? All of those are important genetic counseling questions that we really can only address if we have the mutation in hand. It's also important, as I said at the very beginning, and partly you can see by the set of companies that are helping to support this program, for some of the clinical trials, the patients will only be eligible on the basis of knowing the exact specific mutation. So patients on PTC124, also now called Adalurin or Translarna by PTC, won't be eligible for a nonsense read-through drug unless they have a nonsense mutation that's relevant. Similarly, the two drugs that are moving forward right now are part of a spectrum of different exon skipping drugs, so drisapersen and eteplirsen for skipping exon 51. One would need specific information that individual patients are relevant for those studies to be able to be enrolled in the studies. This will become more and more an ingredient of all clinical trial participation for Duchenne, and that's appropriate and good to keep pushing forward in that area. Actually, just the slide saying the same thing. And the family risk information, one of the reasons that even if the clinical testing fails, it's worthwhile to keep pushing for the mutation detection, is that without knowing that exact mutation, you really can't provide the guidance to the rest of the family members who are at risk of either having manifestations of being a carrier, which is a serious issue itself, or for family planning issues. So there are some issues of retesting, and this does come up. We also still have patients that are surviving long enough and were born and diagnosed before the gene was identified, so have never gotten genetic testing. There's a few of those individuals, but also some of the individuals who got really early testing maybe didn't get a full spectrum of all exons being observed, so we don't really know their exact boundaries. And some of those people really ought to be repeated with modern techniques. So that I'm going to hand back to Dan. Yep.
Great. Thank you, Stan. This is Ann Lucas. I'm one of the other genetic counselors that work with Duchenne Connect and PPMD. And I want to take this opportunity to actually introduce a family that has gone through the Decode Duchenne program and kind of get their story, so kind of get an idea of why it might be important to a family, why this can make a difference. So, Kimberly, are you on the phone?
Yes, Ann, I'm here.
Great. Thank you for joining us. This is Kimberly. And Kimberly, thank you for agreeing to tell us your story. Can you tell us about your son and how his diagnosis came about?
Yes. So my son is Trent. You can see him if you're joining us on the web. He is going to be 1 year old, actually next week. So we had kind of a unique situation where we found out his diagnosis. We went for a regular well checkup visit, at 5 months and realized that he didn't gain weight from his previous visit at 3 months. So the doctor was obviously concerned and ordered some regular blood work. The blood work showed that he had elevated liver enzymes. It really wasn't anything that they were super concerned about. They sent us to a specialist who helped us with his weight gain, and she continued to monitor the liver enzymes. It was about 2 months of fluctuations in his enzymes that the doctor ordered additional battery of tests, and eventually it led us to an elevated CK. After that, we were referred to a neurologist, and it was suggested that my son has Duchenne muscular dystrophy. After that, we were told the only way to confirm DMD or any other type of MD would be through a comprehensive genetic test.
So first of all, we have to point out he is a cutie pie.
Oh, thank you.
Yeah, and I'm sorry, that sounds like a hard time for you and your family, but I'm glad that you were able to get to us. So how did you hear about Decode Duchenne genetic testing program?
So when we met with the neurologist, we met in a neuromuscular clinic, and they were actually really great at referring us to the Decode Duchenne program, and they right on the spot, they actually looked at our insurance and realized that our deductible was extremely high, and they immediately referred us to Decode Duchenne, and they told us how to apply, which was super easy. We just had to go on and register, and then they had the test completed within 2 weeks.
That's great.
It couldn't have been any easier.
That's wonderful to hear that your clinic knew of our program, and that we were able to help. So now knowing your diagnosis, how was this program helpful for your family?
The program has been helpful in so many ways. The testing allowed for us to confirm our son's diagnosis with the added benefit of no additional financial strains. And then the information that was presented in the genetic test gave us valuable insight about transgenetic mutation. We're new to this, so the more I'm learning about his mutation, the more valuable I know that this information is, because it's helping us to determine what developing therapies will work for our son. And it actually turns out that he is able to participate in one of the drugs that are in development right now, that his nonsense mutation works for Adalorn. So without this information, we would have never known, what would be helpful for him or not. And then 2 weeks after his genetic testing results were told to us, and I found myself, finally able to wrap my head around everything, I realized that I didn't really understand his mutation, and that all the stuff that the genetic counselor at the clinic had told me, didn't really make sense to me. I had no idea what was going on, and it was really frustrating me as I was trying to educate myself. And that's when I reached out to a genetic counselor through Decode Duchenne, and her conversation was life-changing. She really broke it down for me and put it in terms that I would understand, and really helped me to understand what was going on and what I need to look for. And then not only did she talk to me on the phone about it at length, but she also sent me a typed summary of the conversation, which has allowed for me to refer back to this, the terminology that was used. And then it also helped me share information with family in a way that everyone can understand. So it helped me, but it also helped my husband and extended family members. And this is really important, especially, going forward, that we all can understand what's going on and do everything we can to help him.
That's great. I'm glad to hear that we were able to be there for you and your extended family. That's good to hear too. And I'm glad you were able to talk with one of the genetic counselors and get your questions answered. So what would you say to other parents and providers who are considering using Decode Duchenne?
I would say absolutely. It was a very seamless process. It was not only financially helpful, but it's been emotionally helpful. It's really helped a lot with my family, and you can't really you can't go wrong having counselors on hand to talk to you and kind of go over things long after you leave the clinic is invaluable, and it's just highly recommended. It's been a wonderful experience for my family in a sad situation.
Yeah. Well, thank you so much for sharing your story and showing us Trent. He's beautiful, and we wish you the best. And thank you again for being with us today.
Thank you so much.
Yeah. So our next slide is just, again, the steps that if you're interested, if you're on the webinar today, or if you watch this as a recorded version, you can always contact us via email at coordinator@DuchenneConnect.org, or give us a call at 201-937-1408, or visit our website at DuchenneConnect.org. The forms for the Decode program are there on the website. You can download those, complete them, and then send them to us. And even if you haven't had testing through Decode Duchenne, but you do have a question about your genetic test result, or just about genetic testing in general, give us a call or an email, and we'd be happy to talk with you about any of that. And help us spread the word about Decode Duchenne. We're trying to let anybody who needs help with genetic testing know about this program. So if you come across any other healthcare providers that may have other families that they could refer, please tell them about it. Direct them to our website. Help us get the word out about this program. The next thing I want to do is share with you a little video that we have created just to highlight what our registry actually does. This is the first showing of this webinar. It's a short 1-minute video, so enjoy.
Duchenne Connect is a registry for people who have Duchenne and Becker muscular dystrophy. Women who are carriers are also invited to join. Sharing your story through Duchenne Connect shows what life is like for people who have Duchenne and Becker, and helps us to identify your biggest concerns. Doctors and researchers use this data to improve care and develop better treatments. None of these people can do it alone. We need you. When you join Duchenne Connect, you'll answer some surveys. Based on your answers, we can send emails about research studies you may qualify for when those researchers use the registry to help with recruitment. Duchenne Connect has the latest updates on clinical information. We have webinars about important health topics and frequently asked questions about research. Your privacy is important to us. Everything is stored securely. We never share your name or contact information. If you have questions, talk to one of our genetic counselors on the phone or by email. You have the power to make a difference. Help us end Duchenne.
Okay, so we're at the end of our webinar, and we just want to open it up to some questions. Daniel, I think there's questions already in the chat box. I don't know how you want to address all of these.
If you just click on the question part, you can see all the questions.
So I think Jillian had the first question. Her question was, the spectrum of Duchenne is crazy. What causes one boy to be worse than the other? And does the type of mutation contribute to the severity of Duchenne? Stan, do you want to take a stab at that?
Sure, I can address that. There's certainly a lot of the information for why boys with DMD mutations and mutations in the DMD gene that encodes dystrophin have very different presentations. So part of it we understand really, really well, and that is boys that have some dystrophin that's being expressed in frame tend to have the allelic disorder, Becker muscular dystrophy, and sometimes that can be quite mild. So in many instances, we consider, is the mutation amenable to possibly being able to make some in-frame protein? That's part of the answer, is that some boys have a Duchenne, a DMD mutation, but indeed make some dystrophin protein. So we know that from actually some of the mutation analysis of the DMD gene. However, there's also a spectrum of how severe boys are who have no dystrophin expression on muscle biopsy. So their genetics don't matter in the sense that the mutation has resulted in the same thing. There's no dystrophin. And that's 95% of all Duchenne boys actually fit in that category. So when you take that category of boys, we can see from Duchenne Connect in the data, some boys progress to lose ambulation early in life at age 4, 5, 6 and have a very severe, more rapidly progressive disease. Others are actually still walking in their late teenage years, 17, 18. Some of that possibly due to care, possibly age at time, steroids, et cetera. So we are modifying the disease process. But some of that we would hypothesize might be due to other mutations in the genome or other epigenetic effects. So, for instance, we have a project where we'll be sequencing the whole genomes of boys that are quite variable, either presenting with a very severe disease course or boys that are presenting with a relatively more mild disease course. And that study will involve the whole genome sequencing of those boys to try to get that at much higher resolution. But we don't necessarily know for all of them. There are 2 different alleles that have been identified that appear to be modifiers, but they're very modest modifiers of the disease process. One's in a protein that binds TGF-beta, and the other one's in an important immune modulatory protein.
I hope that answered your question. And just to note, if we don't get to all the questions today, we will address each one of those after the webinar. So if you do have a question, please type it into the chat box, and we'll try to get to you. There's another question came in about, could you talk a little bit more on the nonsense mutation, specifically nonsense stop codon on exon 55?
I'm happy to jump in to answer these questions.
Sure, go ahead.
So nonsense mutations, almost regardless of where they occur in the gene, would be predicted to lead to no functional protein. That would certainly be true in exon 55 and would be predicted to be causing a Duchenne phenotype. So that particular mutation would be relevant to the strategy of a read-through strategy like PTC124, also called Adalurin or Translarna. And many boys in the U.S., for instance, are actually on an extension of a clinical trial for that drug as we speak. And PTC124 has conditional approval through the EMA in Europe and will be, per report, bringing what their new drug application is going to look like to the FDA in reasonably near term. So quite relevant new therapies coming forward for that mutation.
That's good. That's great. Another question is from a family who we've been familiar with for a while, and their son's been given a Duchenne diagnosis since 1995. They've gone through our testing program with Emory and ruled out Duchenne and other forms of neuromuscular diseases with the panel. And this family's wondering if your testing through your lab, your research testing, could help figure out his form of muscular dystrophy.
It might. So we're happy to take the sample in and consent them for that trial. Better is if we have an actual muscle biopsy from the child that got performed. So for many of the kids where we never come up with what's a clear molecular answer, which we can usually do, you can actually do it from saliva or blood, those are totally fine. Many of those boys actually have a muscle biopsy, and even if it's 20 years old, we can sometimes use it to extract RNA, and that can often be a very valuable part of the diagnostic workup for those that really might not have Duchenne, or they might have a mutation that's just really, really hard to see. So some of the new genetic techniques for DMD gene are important, but then also looking elsewhere in the genome for possible causes is also important. So absolutely.
Okay.
We'd like to solve all of the cases.
So with the muscle biopsies, if they've never had a muscle biopsy, what would you suggest if they've gone through all those different steps?
Yeah, so I think that my suggestion would be a careful review of the medical records. We're happy to do that. If it's a fairly typical progression of Duchenne, which obviously the family would know by now, he's quite old, that those individuals would benefit from a muscle biopsy. Sometimes figuring out exactly what and where to biopsy can be challenging, particularly if it's in a 25-year-old young man. So I think those are discussions that we'd have to have on an individual basis to try to come up with what the exact diagnosis for that person.
Okay, thank you.
And sometimes, honestly, we can't find them. So.
Right. I mean, there are limitations still, unfortunately, even though it's 2015.
Yep.
So another family has written in, their son has a positive diagnosis with a deletion 46 through 50, but it was done by PCR, and they're asking if it needs to be repeated to investigate the breakdown further.
Not necessarily. The MLPA is a form of PCR-based testing that was quite probably what was done, and that's adequate to do. The 46 to 50 deletion in terms of the strategies for repair, if one were going to put it in frame, it would be skipping exon 45 and 51, which is obviously going to be a more difficult task, if possible, to do. What people will question about is do we know exactly where in the intron the breakpoints are if all we've done is look at the exons, so we know the exons are missing. In general, it's not critically important, and the introns are quite large, so typically the mutations occur, substantially far from the edges of the exons and wouldn't interfere. So in general, I would say no, but it would depend on what exactly the PCR-based testing is. And I would suggest for that person that they just send in what their report looks like to the GX counselors at Duchenne Connect, because I think you guys would be expert in knowing whether it's modern technique or not.
Okay. Yep, sounds good. So, yeah, anybody can send their reports to us. We do ask for anybody who joins Duchenne Connect to send us or upload a copy of your genetic test report into the registry. This helps us verify your diagnosis, and we do take the information from the actual report, and we take specific pieces of information from that report and curate that data so that it's easily searchable. And like the video said, everything that we do with Duchenne Connect, any data that we use is de-identified. We never share your contact information. And even the people at the rest of the workers at PPMD don't have access to Duchenne Connect. It's just the curators of Duchenne Connect who have access to the data. Okay. One family is writing in about the infusion trial with treating nonsense mutations, and what is that actually supposed to do? How does that work?
So I think that one's probably a mixed question. There's a Pfizer infusion trial. The Pfizer infusion trial that I'm aware of is an anti-myostatin antibody. Mm-hmm. So it's a humanized antibody. It's enrolling fairly slowly at the UCLA and multiple other centers, and is intended to suppress myostatin, which is a perfectly plausible strategy. It would be relevant to nonsense mutations, frame-shifting mutations, and is not necessarily specific to nonsense mutations unless there's something else that the person was asking about.
Okay. And that you bring up another point that I wanted to make sure people realize. On our website, we have FAQs, or frequently asked questions, about some of the different trials. So if you have a specific trial that you wanted to get more information on it, you could go to our website and look for that particular study. Clinicaltrials.gov also has a listing. It's a free site. Anybody can go to it and find clinical trials that are out there. And those, in addition to our FAQs, clinicaltrials.gov also gives you the contact information, just as we do for wherever the trial is being held. The next question is asking if Emory is reporting out variants of uncertain significance when doing DMD testing, and if so, what are some of the steps you suggest clinicians do to follow up on these inconclusive results? And the last part of that question is this common occurrence for the samples you've tested so far? As far as the routine DMD testing, most of it is pretty straightforward. If there is something uncertain, they do report it out, but they do try to give any clinical information they possibly can. There are databases out there that they use and other types of mechanisms that they use to try to give us potential information what that variant could possibly do. Is this a common occurrence for the samples you have tested? No, it's not. Now, when you get into something like a neuromuscular disease panel test, when you're looking at multiple genes at one time, you have more chance of that happening. So it becomes a little bit more common for that to happen. And Martin, I don't know if you want to add anything else to that.
Yeah, I was just going to say the same thing, that it's unusual for a variant to come up on just the traditional testing, but once we get into the neuromuscular panels where they're looking at 80-some genes, that we do tend to get a lot of variants, and Emory does report those, but yeah, the significance is obviously unknown. So at that point, we still don't have an answer, unfortunately.
Right. Okay. And Stan, anything else that you wanted to add on that question?
No, I'd say in those instances where occasionally we do deal with the issue that I don't know about from the Emory report per se, but the typical laboratory will report variants of uncertain clinical significance. Almost always they're not affecting reading frame, and we have no prior evidence that they're affecting, or they have such a high allele frequency in the population we can completely exclude them. So if people have those types of questions, I think it's a great thing, and I think actually it would be pretty straightforward for any of the genetics labs to assuage any concerns that they may be the true causal mutation for DMD. It's very, very rare that they are.
Right. Okay. And another family has a question about the status of Adalurin in regards to being approved and being able to be prescribed by physicians.
Sure, I'll take that. At UCLA and many other places in the U.S., patients are on it, but on it as part of a study. Some newer diagnosis patients are not on those studies and are not receiving it in the U.S. In the EMA-covered countries, it has conditional approval, and therefore it's theoretically possible to prescribe, but not necessarily covered financially by either the state or private insurance programs there. So it's not, certainly not widely available yet, and not easy to be able to administer to folks, and it is not FDA approved in the U.S. yet.
Okay.
That's my info.
Yep. Anything else, Anne, that you wanted to add?
No, I don't think so.
Okay. Another question is, can families use just the genetic counseling portion of Duchenne Connect? For example, if they've already had their genetic testing. Yes, definitely contact us with any of your questions. You don't even have to be registered. We can talk to anybody who emails us or calls us with any of your questions. So that's what we're here for. Let's see, we have a few more questions. This is a family who has a daughter who's been diagnosed as a manifesting carrier. She's 10 years old, and they're having problems connecting with other girls in her situation. They're having an extremely difficult time finding information on progression, and they're looking for any information, thoughts, or comments on finding more information. I don't know if you have any thoughts on that first. I know we can give them some information, but.
Yeah, I was just going to say, if you want to, for the mother who asked this question, if you want to send us an email, we can actually try to connect you with other manifesting carriers within the registry. We can't give you their information, but if you give us permission, we can contact them and give your information if you would like to try to network with some of the other registrants who have a daughter who's a manifesting carrier.
And I'll just comment that sort of knowing exactly how a given girl who's a manifesting carrier is going to progress is a more challenging thing than even a typical boy with Duchenne, partly because we don't sample all the muscles, we don't necessarily look thoroughly. Oftentimes it's due to non-random exon activation, and we don't have a mechanism to survey truly what the muscles all look like. So giving specific guidance is difficult and more challenging. And there are some girls who really manifest, completely a phenotype that's indistinguishable from Duchenne muscular dystrophy in boys and have a very severe manifesting case. And the clinical course will tell the clinical team, how best to be managing her.
Yeah. And one other thing I wanted to point out is a couple of things. On the PPMD site, we have community pages, which is separate from Duchenne Connect. The community pages is more like a Facebook for PPMD, people who want to be part of PPMD. And if you join that community page, you can find other people. There's subgroups within that community that you might be able to also connect with, people that have similar interests as you. And the other thing I wanted to mention is for carriers, we are starting to focus more on carriers, and we want to find out what are their concerns and problems that they're having. So if you want to shoot us an email or give us a call and talk to us about that, we'd be happy to do that. I think we are out of time. We have a couple of questions, but we'll have to get to those after the webinar is finished. I did want to mention again that any data that's put into our Duchenne Connect registry is secure. We don't share any of your contact information with any outside people. And even the employees of PPMD don't see that information. And it is all used for research, but when you actually create an account on Duchenne Connect, there is a consent form that we ask you to sign, and that goes over all the potential ways that your data might be used. Thank you, Stan, so much for being with us, and thank you, Tim, as well, for being with us today. And thank you to the three companies who have supported this program. This is a great need in the company, and we're just so happy to be able to offer this to the community.
Very good. Thank you, guys.
Thank you, everyone.
Thank you. And again, follow us on Facebook and Twitter, or email us and call us, and we'll be happy to answer your questions.